I रिकॉर्डिंग हो रही है अब?
जी
ओके. Today we will be discussing renal tubular acidosis. We have already discussed glomerular lesions like nephrotic syndrome and nephritic syndrome, and we have also discussed one of the tubular disorder, that is tubular interstitial nephritis. Now today we will be discussing renal tubular acidosis. Now, renal tubular acidosis is a medical condition leading to accumulation of acid in the body, as the term signifies, acidosis. There is accumulation of acid in the body, and the main reason is failure of the kidney to acidify urine. You see, one of the important functions of the kidney is the pH balance, and that is maintained by producing acidic urine. So failure of the kidneys to produce acidic urine. This leads to metabolic acidosis with a blood pH of less than 7.3. Now, this failure of the kidney to acidify urine can be because of two reasons. Number one, failure to reabsorb bicarbonate, which is primarily the function of the proximal tubule. If bicarbonate is not reabsorbed, there will be acidosis, and bicarbonate will be lost in the urine. Or the secretion of hydrogen ion in the distal tubule. Hydrogen ion is one of the element which helps in the elimination of the acid from the body. So if hydrogen is not secreted and passed into the urine, it again leads to accumulation of acid in the body. The important thing to remember is that in RTA, there is poor acidification of the urine, but usually the kidney functions are well preserved. So kidney failure is not there. It is only the acidification of urine which is at fault. Metabolic, and in here I would like to emphasize that there is metabolic acidosis in renal failure also, and the pathophysiology is different from renal tubular acidosis, and metabolic acidosis of renal failure is not included in renal tubular acidosis. Renal tubular acidosis is usually an incidental finding because most of the time the patients do not have impaired kidney function. They usually are referred or come up with the blood reports. 4 different types of renal tubular acidosis have been described. As we all know, 1 million nephron, we have already discussed this thing. It's each nephron is the independent functional unit. Glomeruli are responsible for the ultrafiltration, which is usually GFR is 120 ml per minute, and the primary job of the tubule is proximal convoluted tubule, reabsorption, secretion, and excretion. Proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting duct. Their main function is reabsorption, secretion, and excretion. So instead of passing 170 liters of urine in a day, by the process of reabsorption, secretion, and excretion, we are able to pass 1.5 liter of urine per day. Usually 1.5 to 2. Now these are the different parts of the nephron. Concentrate on proximal convoluted tubule, adjust the filtrate of the pH, and again, the distal convoluted tubule, which is responsible for maintaining the blood pH and electrolyte balance. You have to keep this in mind. Now, again, the functions of the proximal convoluted tubule, it in fact reabsorbs everything which is filtered from the glomeruli, like glucose, amino acids, protein, vitamin, lactose, urea, uric acid, and electrolytes. Similarly, in fact, 99% of reabsorption occurs at proximal convoluted tubule. And then there is selective reabsorption and secretion. For example, in the distal part of the proximal convoluted tubule, there is secretion of the hydrogen ions, and ammonia secretion is also there. Similarly, the distal convoluted tubule, hydrogen ion is secreted into the urine and is passed out. This is again same things. Now, before proceeding further with renal tubular acidosis, what type of acidosis is renal tubular acidosis? Basically, it is metabolic acidosis with a normal anion gap. It's a normal anion gap acidosis. Now, what is anion gap? Anion gap is the difference between cations and anions in the serum or urine. The magnitude of this difference, that is gap, is calculated to identify the cause of metabolic acidosis and low pH of blood. How do we calculate anion gap? It's very simple. Serum sodium minus chloride plus bicarbonate. The usual normal range is 8 to 16 milliequivalent per liter. Sometimes they do add chloride plus bicarbonate plus potassium, but since the value of potassium is very low, so ideally, for practical purposes, the usual equation used is sodium minus chloride plus bicarbonate, and the normal range is 8 to 16. Now, increased anion gap can occur because of influx of organic acid in the plasma. Any type of acid which is in the plasma will increase the anion gap. And the normal anion gap is usually because of the loss of bicarbonate, may it be in the stool or in the urine, and it usually leads to hyperchloremia. Because once bicarbonate is a negatively charged ion, so when it is lost, compensatory there is chloride ion, which are also negatively charged, are increased. So it is also called hyperchloremic metabolic acidosis. Now, what are the causes of normal anion gap metabolic acidosis, which is hyperchloremic? There could be causes in the GI tract like diarrhea, hyperalimentation, ureterosigmoid fistula, or pancreatic fistula. Then there could be renal losses, as in because of drugs like acetazolamide, proximal, distal, and hyperkalemic renal tubular acidosis. Any type of acidosis will lead to renal loss of bicarbonate. And then there are miscellaneous rare causes like ammonium chloride ingestion, which is usually given in patients of urinary tract infection to acidify urine, sulfur ingestion, flowers of sulfur cataratic, hydrogen sulfide, they are ingested, and toluene inhalation, glue sniffing, which is common among the poor masses of the country, that can also lead to renal tubular acidosis. The simple and mnemonic to remember the normal anion gap metabolic acidosis is harder. H stands for hyperalimentation, A stands for acetazolamide, R stands for renal tubular acidosis, D for diarrhea, U for sigmoid fistula, and P for P for pancreatic fistula. Now, as I said, whenever there is influx of organic acid into the plasma, it leads to high anion gap metabolic acidosis. Now, what are those organic acids? Like ketoacidosis in diabetic, alcoholic, in starvation, and paraldehyde. Lactic acidosis, anaerobic cycle, when it is used, it can lead to lactic acidosis and influx of acid into the bloodstream. Intoxications like ethylene glycol, methanol, salicylates, iron can all lead to a high anion gap metabolic acidosis if used in toxic doses. And advanced renal failure. Advanced renal failure is basically a high anion gap metabolic acidosis. It is not a normal anion gap metabolic acidosis, and it is basically this is because of uremia. The mnemonic for high anion gap metabolic acidosis is multiple. M stands for methanol, U for uremia, D for diabetic ketoacidosis, I for iron, L for lactic acidosis, E for ethylene glycol, and S for salicylates. You can remember the mnemonics so that you can know the common causes of high anion gap and normal anion gap metabolic acidosis. Now, on the basis, we have come to know that it's a tubular disorder in which there is a defect in the acidification of the urine, and on the basis of the part of the tubule involved, it is classified into 4 types. Classical or distal renal tubular acidosis, proximal renal tubular acidosis. Type 3 is a combination of 1 and 2. And type 4 is hyperkalemic renal tubular acidosis. This is also a distal renal tubular acidosis. So classical distal renal tubular acidosis, proximal renal tubular acidosis, just ignore type 3, which is combination of 1 and 2. And type 4 is again hyperkalemic distal renal tubular acidosis. Now, distal renal tubular acidosis, it is also called hypokalemic renal tubular acidosis. In fact, in all type of renal tubular acidosis, there is hypokalemia except type 4. The main defect is in the distal tubule and collecting duct. Normal anion gap metabolic acidosis, hypokalemia, hypercalciuria, hypocalcemia, and hyperchloremia. Hyperchloremia, since it is we are losing a lot of bicarbonate, that's why there is compensatory increase in chloride, so it causes hyperkalemia. And we will be discussing the pathophysiology of hypercalcemia and hypocalcemia in distal RTA. Now, the pathophysiology of type 1 distal RTA is it is characterized by failure of acid secretion by the, that is hydrogen ion, by the alpha intercalated cells of the cortical collecting duct of the distal nephron. Alpha intercalated cells, you must have read intercalated cells in your physiology. So it is the failure of acid secretion by the alpha intercalated cells of the cortical collecting duct of the distal nephron. Thus, failure to acidify urine to less than 5.3 pH, producing alkaline urine, leading to acidemia. Now, as a result, potassium cannot be reabsorbed by the alpha cells. Non-functioning hydrogen potassium antiporter of the intercalated cells. So, what happens is that hydrogen ion is secreted. Hydrogen ion is secreted and potassium ion is reabsorbed. So to maintain homeostasis, that is controlled acidemia and maintain potassium ion. So this is basically the non-functional antiporter cells of the intercalated cells, resulting in proton, that is hydrogen retention and potassium excretion. Now this, since the hydrogen is not being secreted, so the urine is not acid, it is basically alkaline. This alkaline urine leads to the calcium phosphate deposition, resulting in bilateral renal stone and nephroconcentrations. So basically, alkaline urine is the culprit, which leads to the deposition of calcium and phosphate, resulting in bilateral stone. Now, causes, you just have to remember few of the causes, like it can be sporadic, it can be autosomal dominant or recessive, autoimmune diseases like Sjogren, SLE, rheumatoid, hypergammaglobulinemia, liver cirrhosis, medullary sponge kidney, renal transplantation, sickle cell anemia, toxins like lithium and amphotericin, and obstructive uropathy, bilateral calculi, pyelonephritis, or vesico-ureteric junction obstruction. These are a few of the common causes of distal renal tubular acidosis. Now, the clinical feature of distal RTA is there is normal anion gap metabolic acidosis. The anion gap is less than 12, pH is less than 7.3, and serum bicarbonate is less than 18. Usually, the patients are asymptomatic or they may present with pain in the lumbar region and hematuria. That is basically because of the kidney stones, which are quite common in distal RTA. Dehydration is a feature, sodium loss and volume contraction. This is basically because of hyperaldosteronism, increased aldosterone level. Hyperaldosteronism, increased sodium resorption. Again, there will be, whenever there is a sodium resorption, there is a loss of potassium in the collecting duct, resulting in hypokalemia. Urinary pH is 5.5, alkaline urine, and urinary stones are produced in the alkaline urine secondary to hypercalciuria and low citrate levels. Bone demineralization occurs, resulting in rickets and children and growth failure. This is the photograph of bowing of legs in rickets and osteomalacia in adults. This is calcification in the in the kidneys because of deposition of calcium, resulting in kidney stones. Again, a radiograph of rickets, bowing of legs. Now, how do we diagnose distal renal tubular acidosis? First, you have to calculate the anion gap. It should be less than 12. Serum bicarbonate should be below 20, that is 18 milliequivalent per liter. There is hypokalemia, 3.5 potassium or low, and urinary pH is usually high, above 7. You can also calculate urine anion gap. This is the equation: urinary sodium plus urinary potassium minus chloride. If it is minus 20 milliequivalent per liter, then it is basically bicarbonate is lost from GI. But if it is plus 23 milliequivalent per liter, the bicarbonate loss is from distal tubule, renal tubular acidosis, which is distal renal tubular. Urea and creatinine, as I said, is normal, and you have to exclude renal failure. You can calculate 24-hour calcium estimation for identify to quantify hypercalciuria. Ultrasound may show obstructive uropathy, stones, and nephrocalcinosis. Incomplete distal RTA, you don't have to go through it. It's in which there is some acidification of the urine, and then there are confirmatory tests for it, but I don't think it is important. Hereditary distal renal tubular acidosis because of genetic mutation early in the life, failure to thrive, gastrointestinal loss of appetite, constipation, and diarrhea in urinary polyuria, polydipsia, and dehydration, medullary cyst, hearing loss, and hemolytic anemia. Biochemical abnormalities of urine and blood are the same as in distal RTA. Treatment of distal renal tubular acidosis is straightforward. You just have to correct acidosis by administration of sodium bicarbonate or sodium citrate. You have to correct hypokalemia, you can use potassium citrate. Salt solution is a good solution. You have to get it from the dispensing chemist. It consists of sodium citrate and potassium citrate. These measures will reverse the bone demineralization, replaces potassium, inhibits calcium excretion, and avoid stone disease. In fact, in all forms of renal tubular acidosis, the mainstay of treatment is bicarbonate supplementation. Now we come to type 2, proximal renal tubular acidosis. Proximal renal tubular acidosis is caused by a failure of proximal tubular cells to reabsorb filtered bicarbonate. There is usually bicarbonate wasting and acidosis. The distal tubular, here you have to remember this thing, that distal tubular intercalated cells are functioning normally. Thus, hydrogen ion secretion is there. Thus, the acidosis is less severe as compared to distal RTA. Urine can acidify to pH less than 5.3. Proximal RTA is usually associated with generalized dysfunction of proximal tubule called Fanconi syndrome. The causes of proximal renal tubular acidosis is primary autosomal dominant, which is rare autosomal recessive, which can occur with ocular abnormalities and mental retardation, and it can occur also sporadically. Secondary causes are familial, like cystinosis, galactosemia, glyconestoidosis disease, and Wilson disease. Acquired, like amyloidosis, multiple myeloma, Sjogren disease, syndrome. Toxins like highly active antiretroviral therapy for HIV, anti-cancer drugs, chemotherapy, acetazolamide, aminoglycosides, heavy metal poisonings like lead, cadmium, mercury, and copper. These all can present as Fanconi syndrome. There is generalized proximal tubular dysfunction. Hypophosphatemia is a feature of type 2 renal tubular acidosis resulting in phosphaturia. There is renal glycosuria, in fact, everything is passed in urine. Renal glycosuria, aminoaciduria, proteinuria, these all are features of Fanconi syndrome. Now, this is the diagrammatic representation. Renal proximal tubular dysfunction resulting in phosphaturia, renal glycosuria, aminoaciduria, proteinuria, and proximal renal tubular acidosis. Now, there is a defect in this diagram. The arrows are pointing towards the wrong side. This usually shows that these things are being absorbed. In fact, these things are not being absorbed. They are retained in the proximal tubule: sodium, phosphate, bicarbonate, glucose, and amino acids, and then they are excreted out. So there is a flaw in this diagram, that these arrows should be pointing inwards. Genetic disease, they have also shown genetic disease, cystinusis, Wilson disease, and acquired like heavy metal poisoning in cisplatin. The clinical features include growth failure, hypovolemia, persistent acidosis, rickets, and osteomalacia. This is also called hypophosphatemic rickets. Constipation and weakness are because of hypokalemia. The clinical manifestations of Fanconi syndrome are growth failure, hypophosphatemia, acidosis, and hypokalemia. Volume depletion as a result of water loss, impaired concentration and ability of the kidneys. Rickets and osteomalacia because of hypophosphatemia and low vitamin D3 levels. This is also called hypophosphatemic rickets. Constipation and muscle weakness because of hypokalemia. Patient with systemic disease will present with additional signs and symptoms specific to underlying disease. Nephrocalcinosis and nephrolithiasis is rare because of high citric acid secretion, and there is comparatively less hypercalciuria. So nephrocalcinosis and nephrolithiasis is not a feature of Fanconi syndrome, it's a feature of type 1 renal tubular acidosis. This is the diagram of hypophosphatemic rickets. Again, poor legs. Diagnosis is made by clinical symptoms and signs. You have to calculate anion gap. It should be normal. Bicarbonate is low. Acidosis is not as severe as in RTA because the interconnected cells of distal nephron are secreting hydrogen ion. pH is less than 5. Hypokalemia and hypophosphatemia as a feature. Phosphaturia, glycosuria, amino aciduria, uric aciduria. X-ray features of osteomalacia and rickets. And ultrasound kidneys is negative for nephrocalcinosis or any structural abnormality. The treatment, again, as I said, the mainstay of treatment of all types of renal tubular acidosis is bicarbonate supplementation. Large doses of sodium bicarbonate is given in divided doses. It is available. It's a very cheap drug available by the name of Sodamend. Previously, it was commonly used for GI disturbances and acidity. Potassium supplementation, potassium chloride syrups or tablet, and there is a tablet by the name of Uracet K, which is a potassium citrate. Again, salt solution, sodium citrate and potassium citrate combination. If you want to replace sodium orally, then syrup sodium phosphate, which is 86.5 milligram per ml. Vitamin D supplementation is usually required in these patients so as to increase calcium and phosphorus absorption from the gut. It helps in the treatment of hypophosphatemia. Type 3 is a mixture of type 1 and type 2. Type 3 is usually excluded. Yes, you have to remember this thing. Whenever somebody asks for the classification of renal tubular acidosis, you can say type 1, type 2, and type 4. Type 3 is no more in the classification of renal tubular acidosis. It has feature of both distal and proximal RTA. It's a rare pattern usually observed in 1960s and 70s in some infants when children with distal RTA, possibly due to high salt intake, and it is also called juvenile renal tubular acidosis. It can be because of inherited carbonic anhydrase 2 deficiency. It's an autosomal recessive infantile osteopetrosis, which is also called marble bone disease, renal tubular acidosis, cerebral calcification, and mental retardation. Majority of cases were reported from North Africa, possibly because of intermarriages. Treatment is same as of type 1 and type 2. No treatment is available for osteopetrosis or cerebral calcification. This is a diagram of one of the complications of type 3 marble bone disease. Now, this is an important renal tubular disorder. It is basically not a tubular disorder. The main defect is in the adrenal gland. Absolute hypoaldosteronism or aldosterone. As we know that adrenal gland produces aldosterone. If there is no production of aldosterone, which is also called or there is aldosterone is being produced, but the kidneys are insensitive to aldosterone. There is mild normal anion gap metabolic acidosis. It is due to physiological reduction in proximal tubular ammonia excretion because of hypoaldosteronism. Hypoaldosteronism leads to reduction in proximal tubular ammonia excretion. The cardinal feature of type 4 renal tubular acidosis is hyperkalemia and acidosis. Metabolic acidosis with hyperkalemia is a feature of type 4 renal tubular acidosis. Hypokalemia is not in type 4. If you find any patient with a low potassium level, it is definitely not type 4 renal tubular acidosis. Now, basically, type 4 RTA is impaired production of aldosterone, as I said, Addison disease, or impaired response to aldosterone, which is called pseudo-hypoaldosteronism. Aldosterone is being produced, but the kidneys are not responding. In children, pseudo-hypoaldosteronism is common cause of type 4 RTA, basically because of acute or chronic pyelonephritis or any form of obstructive uropathy, may it be acute or it can be rarely an inherited type of RTA is also identified. Hypoaldosteronism leads to, this we are discussing the pathophysiology of type 4 RTA. Hypoaldosteronism leads to physiological reduction in proximal tubular ammonium excretion. You see, whenever there is lack of aldosterone, the proximal tubular ammonium excretion is also impaired. Hypoaldosteronism has a direct effect on distal tubular intercalated cells. There is impaired hydrogen ion secretion, leading to metabolic acidosis. And hyperaldosteronism inhibits potassium secretion in collecting blood, which is usually exchanged with sodium. So potassium secretion is impaired and there is hyperkalemia, resulting in mild metabolic acidosis and hyperkalemia. Causes can be sporadic and hereditary. Secondary causes include Addison disease, adrenal tuberculosis, pseudohypoaldosteronism, obstructive uropathy, pyelonephritis, interstitial nephritis, diabetes mellitus, sickle cell nephropathy, kidney transplant rejection, and drugs like ACE, cyclosporin, heparin, NSAIDs, and potassium-sparing diuretics. The clinical manifestation and diagnosis include same normal anion gap metabolic acidosis. Hyperkalemia is a very serious condition which may be life-threatening, leading to cardiac arrest and arrhythmias. Polyuria, dehydration, weight loss. These patients are usually severely dehydrated because sodium is being not reabsorbed and resulting in excessive loss of water. Urine may be alkaline or slightly acidic. Elevated urinary sodium and low, because sodium is not being absorbed, so elevated urinary sodium and low urinary potassium levels since potassium is not being secreted. In children, there is growth failure, obstructive uropathy, signs and symptoms of pyelonephritis, profound fatigue, and vascular collapse. Postural hypotension is very common in patients with Addison disease. This is a diagrammatic representation of Addison disease, changes in the distribution of body hair, broad segmentation of the skin, GI disturbances, postural hypotension, hypoglycemia, weight loss, weakness. And this may lead to adrenal crisis as a result of profound fatigue, dehydration, vascular collapse, renal shutdown, low serum sodium, and high serum potassium. Treatment of type 4 RTA is all forms of RTA, as I said, bicarbonate replacement. In this also, we have to replace bicarbonate, large doses of sodium bicarbonate, sodamate is given. Sodium citrate can also be used, and you have to ensure adequate hydration. But the one thing to remember is never use potassium citrates or drugs which increase potassium levels, like potassium-sparing diuretics and everything. These drugs should never be used in patients with type 4 RTA. You have to treat obstructive uropathy, may it be pyelonephritis or calculus disease, and treat pyelonephritis with antibiotics. So in conclusion, this is basically a summary of all the types of RTA. If you if you understand and remember the conclusion or the summary of renal tubular acidosis, you have covered almost the entire renal tubular acidosis. RTA is a failure of renal tubules to acidify urine. Four types have been described. Type 1 and 2 are hypokalemic. Type 4 is hyperkalemic. Hypocalcemia and hypercalciuria is a feature of type 1 resulting in stone disease. Nephrocalcinosis and nephrolithiasis is again present in type 1. Rickets and osteomalacia in adults is present in both type 1 and type 2. And failure to thrive hereditary type is present in type 1, 2, 3, and 4. Type 3 is a mixed type of is a mixture of type 1 and type 2 and is excluded from the modern classification. This summary is very important. You have to remember this. And on the basis of this conclusion, you can go back to the lecture and review them how it is possible that somebody with type 1 has got hypokalemia or somebody with type 4 has hyperkalemia. What is the pathophysiology of renal stones in distal renal tubular acidosis, etc. I'm sure that you must have known renal tubular acidosis by now. Thank you.